Hello, everybody. I'm Michael Kerman with Leading Edge Seminars, and to my right or left, whatever you are, I'm welcoming John Briere, who's with us today. I'm very happy to be here with you. These are difficult days, but we're together for this hour with John. I would like to thank JK7 Seminars in the States for spreading the word to American colleagues. And thanks to all of you who've joined for many of our virtual lunches, and which are all available online, by the way, if you've missed them, as is this one. As soon as we finish, you'll get a copy in your box. I do want to say that while we're doing this, my thoughts and probably your thoughts are with the people who are going through horrific experiences these days. That's the reality. And we also honor the heroic efforts of so many people during this difficult time. I'd like to just tell you a little bit about this technical platform. Number one, there may be technical problems, as there often are these days. We've been pretty lucky with this live platform, but somehow if it's not working, my voice you stop hearing my voice, John disappears, your computer turns off. Not to worry. As soon as this is over, you'll get a copy of this. You're welcome to view it today and for the next. There's a question bar in the upper right-hand portion, and that's for you to ask questions at any time. We'll be monitoring those throughout the session. There's also a poll box at the end of this, if you could just take a minute or two to answer a couple of very easy questions. How do you like this? And did the technology work? That feedback is very, very for us. Just a brief mention of what we're doing at Leading Edge Seminars. We've had these virtual lunches for a while, the last 3 weeks. They're all available on our website if you've missed them. People like Mina Fisher and Sue Johnson, a private practice specialist, a person who's been training people on online counseling. He joined me for lunch. It's all free and online. Then we started mini webinars, which are short, usually 2 hours. They're relevant, really offering ideas that you can use right now during this crisis. They're tools, ideas, they're relevant, they're $40, and we have some coming up and some already available on our website. Coming up on Saturday, the only thing we'll be doing the next few days is Stephen Porges with Deb Dana on how polyvagal theory helps us understand and manage our reactions and the reactions of our clients to COVID-19. This is a dialogue between Stephen, who's a scientist, and Deb Dana, who's probably the leading practitioner who's using his ideas to help therapists work with their clients. That's on Saturday. Next week, we have 5 more mini webinars with Frank Anderson, Terry Reel, and other really great people who are with us. And all the focus is on what they do and how they can help you with your clients online. See leadingedgeseminars.org for all that information. It's all there. So now, John, I'm very happy to welcome you here. And I'll give a little introduction, but you can listen to along with everyone else. So John Briere is a professor of psychiatry at the University of Southern California, Keck School of Medicine. He's a past president of the International Society for Traumatic Stress Studies. He's a director of the University of Southern California Adolescent Trauma Training Center, and he's the recipient of all kinds of awards, prestigious awards, for his contributions to therapy, trauma therapy, and research. He's the author of several books, Principles of Trauma Therapy. The second edition came out, and this provides a synthesis of the cognitive behavioral, relational, affect regulation, and mindfulness, and psychopharmaceutical approaches to real-world treatment of acute and chronic post-traumatic stress. He's also the author of Treating Risky and Compulsive Behavior in Trauma Survivors, and he's published 162 articles, chapters, and psychological tests over many years, about 15 years, John. You've been coming to Toronto to present workshops. And I think besides for all the trauma information, support, trauma therapy information you provide, your perspective on being human and the dilemma of being human for all of us, breaking down the difference between professionals and those who serve, and acknowledging with compassion the continuing of trauma or hurt that includes all of us. And that message comes home loud and clear. So, John, welcome very much. Very welcome, and thank you for joining us today.
Thank you.
So, John, I'd like you to start off with bring everyone up to date with what your life has been like personally, professionally, since this crisis hit, and how things are in Los Angeles today.
Well, I think we're all sharing the same experience in North America right now. And I guess for Toronto, last time it was SARS. Now we have COVID-19 for everybody. The worst epicenters for COVID is New York City, which is almost impossible to comprehend in terms of the severity of what they're going through. Los Angeles is obviously a major metropolitan area as well. We're doing a little bit better because we ramped up a little faster. We are starting to redline ICU beds and respirators and things like that, although it looks like we may have as much as a month to get our stuff together before we no longer have capacity. The big deal there is that at some point, clinicians may have to start triaging who lives and who dies, which of course is outrageously difficult. Not that we don't already do that in the burn unit and in oncology and other areas where I work and my colleagues work, but so LA is sort of in a way, I almost feel like we're kind of doing okay. We do have deaths, of course. We do have a lot of clinicians who've been affected by COVID-19. In terms of me, I was appointed because of my role in trauma in Los Angeles County. I'm sort of the guy who's developed the actual protocol and interventions for something called, well, basically it's a program to work with frontline workers who are encountering major stuff in their work with COVID-19. That's a huge, if you think about it, the number of therapists there are out there, the number of ER docs and other people who are actually working with COVID-19, they're collecting quite a lot of trauma and distress associated with that. So we've actually worked on a program to do that. I've done several grand rounds on them for USC Psychiatry. We have a protocol which you could actually maybe get later if you wanted, just the major issues that come up when you're working with frontline workers who are seeing things. So for instance, the role play of yesterday's grand rounds was of a ICU nurse who is kind of falling apart, afraid to go back today because her just found out her mother is COVID positive. She's afraid to spread the disease to her family, so she's now living in a hotel, which is something that people are doing more now. And just her difficulties around all these issues and how in a relatively short period of time do we help her, on the equivalent of a hotline for professional workers. We're also broadening it, however, to not just front lines people, but also therapists, people who are not in the front lines, but administrators, clinicians who are luckily can work from home, et cetera. It's a very intensive process. USC is just, so people like me are just spending all our time on Zoom or Livestorm or whatever, trying to deal with these issues. I myself have not been affected as much as some because a lot of my work is working with the Substance Abuse and Mental Health Service Administration, SAMHSA, in the United States on this thing we've been doing for about 6 or 8 years about rolling out evidence-based interventions for multi-traumatized adolescents who are in socially marginalized environments. We've been doing that for a long time. So a fair amount of my work, in addition to consulting on this stuff, is to do what I've always done, which can be done from home, which is to work on these things. Myself, it breaks my heart because I am in the emergency room and other places a lot. The burn unit, I'm there. I'm not there now, and other people are, and so trying to support my friends and colleagues, but also just you know about all this stuff, but there's not enough PPEs. Well, we have enough right now, but there's always a threat there won't be enough. My friends and colleagues are taking their life in their hands every day. And it's serious, it's real. Many clinicians are in the risk factor area of being 65 or older. There's just so many different issues that are coming together here that it's very hard for everybody. I'm very lucky. I mean, the notion of sheltering in place or being able to work from home, that's sort of a thing that the privileged get to do. And most of the people that we worry about are all the people who have lower socioeconomic status, who are still having to get on buses. They're still serving. Well, our restaurants are shut down, but they're healthcare. They're doing all kinds of things for the elderly. they don't get to stay in houses like we do. They're, you know, I'm in my wife's den right now with intermittent internet, if you wonder why things come and go. Um, that's just a very lucky position to be in. Um, so that, and then I continue to do trauma consultation, and now I'm not actually physically in the burn unit, but do a lot of work in that area as well. I think that's me right now.
Yeah, well, I'd
Yeah,
like to
well, I'd like to
go back
go
to
back to
the,
the
you've had much
much.
okay, I'm getting it, okay. Can you hear me? Oh, I'm losing you, John. I can't hear you.
Oh, well, I
Okay,
can hear me.
okay, good. You've had, you know, more than most trauma therapists that I know of, or teachers of therapists. You spend a lot of time in emergency rooms and the burn unit supporting people, uh, really on the front lines of tragedies and horror. I wonder how this is similar and different in terms of doing and what they are experiencing right now in the hospitals and emergency centers.
We actually have addressed that a little bit in our work, because if you use a classic trauma model, it doesn't perfectly template, because a lot of what people are doing is they're fearing for their own lives, they're fearing for other people, they're very stressed out, the systems are maxed out, these poor ER and ICU workers having to work ridiculous hours in uncertain circumstances. So stress is a huge amount of this, more than, so you know, often in trauma work, we're working with what's happened in the past. With COVID crisis, it's the past, but it's also the present and the future. It's also much more personal for workers, because they could contract COVID, and believe me, one of the biggest worries is they could spread it to their own families. I mean, the heartbreaking stories of a man who wants to go home and be with his kid, and he can't actually go home because if he did, he's afraid he would infect his kid. So it is somewhat different in terms of that. But there are many, many horror stories, and I won't share them now, but many people that I work with have had patients die of COVID right in front of them, that they're responsible for the care. The way that you can sometimes die from COVID can be very graphic. The issues around respirators is very complicated. You've probably heard about this, but many people put on respirators will not come off those respirators and live afterwards. So many people die on respirators. Also, the lungs can decrease their functioning to the point that the respirators don't work anymore. The lungs harden. And then what do you do? How do you work with those people? So I think there's a lot of trauma, but this is a bigger thing about systemic stress and how families meeting with personal, which is meeting with professional. In terms of what we could broadly call countertransference, it's very hard for people to separate out their own fears from their responsibilities. The awful lot of people are overextended, which is bringing out their feelings of insecurity and inadequacy, when in fact they're doing more than we have any right to expect them to do. So a very common statement, I don't really like it because it's kind of militaristic, but what we hear over and over again is this is a war zone now. I hope I didn't give you the impression it's all mellow in LA. It's psychotic in LA. It's just that, believe it or not, it's worse in New York. And I do interact with New York a bit, and you know, that's kind of heartbreaking. So it is trauma, but a lot of times when you're working with therapists and clinicians, you're not just working with discrete events. You're working with much broader phenomena. COVID is all encompassing. It's affecting everybody in every way.
Why did you turn these up?
What happened?
Oh, we just had a little tech. You know, John, we could spend the next hour just talking about what's going on in LA. And people are welcome to ask questions online, any questions you want. But I thought, for a change of pace, because it would be interesting to do a little memory lane trip with you, John, and talk about how you got into trauma work, where you were educated, and your journey. Because one thing I noticed, you've been presenting workshops for us for around 15 years. Each time the workshop's a little bit different, because you're learning, you're integrating new ideas, you're changing, anyway, so can you start from the beginning, where you're comfortable with the John Briere story, soon to be a major motion picture?
Well, you know, as you know, Michael, I'll say anything anywhere, so I'll be just honest with you about that. In my case, I came from a highly violent, dysfunctional family with multiple abusive fathers, and a mother was doing the best she could, but was compromised in her own ways. She's still alive now at 91. We're quite worried, of course, about her in terms of the COVID crisis. So I think I grew up with not only a lot of anger and confusion about myself and maybe pressure about myself, but also almost forced into a compassionate mode of realizing just that the Ozzie and Harriet notion, the happy family that you saw on TV, was so disparate from my experience and my reactions to that early abuse, which involved drugs and troubles and getting big time school problems. I was in special classes for the not quite right for most of my childhood. Those things, I think they could have gone either way, and I'm not sure they didn't go both ways. But I could have just gone way down, or I could have used that and used it to maybe help other people. I think I did both. I've had probably 20 years of therapy, over 10 years of psychoanalysis, multiple therapies at various times. I have been in therapy now for about a decade, but that stuff was very important. So I was in LA. I was in a difficult relationship, which is often what happens when you come up the way that I did. And it was time to apply. And I was getting my master's degree at California State University. I got my BA at UCLA. And it was time to get into a PhD program. And mostly all I wanted to do was escape the dysfunctional relationship I was in, but I did not have the psychological tools to do that myself. So I copped out, as many of us do. And I tried to apply to places far away from LA. And I was thinking, what could be the farthest away place that I could pick? I went, Winnipeg, that's the ticket. So I applied actually to University of Manitoba. Was an APA program then. It's a very good program. I applied there and was accepted. So if you can imagine my first days of being in Winnipeg, I was wearing a loose linen white shirt with Birkenstock sandals. It was September. The winds were blowing off the prairies. It was freezing outside. I couldn't afford a place to live, so I was in the dorms with all these undergraduates. That was interesting. And it was just really quite a shock to find myself in Winnipeg. I eventually became, as you know, very much a Canadiaphile. I love Canada seriously a lot more than I love the United States. And as I was working there, I started working with Neil Malamuth in the Department of Psychology around men's proclivity to engage in sexual violence, which worked for me, the notion of men being aggressive, dangerous beings, because that had been my earlier experience. So my first work was in terms of psychological study of violence, sexual violence, proclivity to rape, etc., pornography with Ed Donnerstein and other people a little bit. But I was in a clinical program, and I had previously in LA worked in psych hospitals to work my way through, especially UCLA. So I had some experience of working with those kinds of people. And then one day, a program that maybe some of your people know about called Clinic with a K in Winnipeg, they asked me would I be willing to do 1 day a week consultation with them for their crisis line program, and then peripherally their sexual assault program, although not obviously as a worker, those were all women, and a battering program they had then, as well as their general crisis program. And I just love that stuff. I think my access to cluster B characteristics that arose from childhood resonated well with the notion of drama, of trauma and crisis work, etc. It also allowed me to work on my own self without knowing that I was doing it. And so that went on for a while, and then it just worked out so well that eventually they made me clinical director of Clinic, and I did that for about 5 years. And during that time was airlifted into the reality of severe trauma. The sexual assault program, I wasn't working with the sexual assault therapist, but I was supervising more broadly, and that was very important. The crisis line calls, especially in those days, I think, maybe it's still the same, but very serious cases would call in the crisis lines because there wasn't much of a trauma infrastructure in Winnipeg to help those people. So these were big cases in many cases. The crisis program, the therapy program, was all trauma survivors. So in Winnipeg, I really started doing this stuff. Then I started, although I didn't do well in school and only got into UCLA on sort of a affirmative action for the not quite right program. They let me in, even though I was literally flunking out of junior high school and high school, but they let me in based on test scores and whatever. I suddenly was in the world of science and numbers and statistics, which is something I've been doing forever. So when I was in Clinic, I started realizing there was almost no research anywhere. So I did this little study, quote unquote, where we looked at I don't even know, a couple hundred people, and I created a measure called the crisis symptom checklist or something And we compared how traumatized and less traumatized people looked in the program and stuff. Not a very good study, had all kinds of problems with it. But when there's nothing out there, then even mediocre work can get more attention. Well, it did. And so what happened was I started publishing more and more on trauma, especially in those days, childhood abuse, because that obviously resonated for me, plus the fact that psychology was discovering just the critical role of the first 8-10 years of life in terms of how you're going to do later. And if those years were bad, that would change your perspectives, your reactions, your capacities, your intrusions of material. So I started just doing that more and more, and met my partner, Cheryl Langtree, there. She was from the Toronto area. I think that she was a little shocked by Winnipeg. We were in graduate school there. So she thought that it was cold and horrid, and that Torontonian notion that only Toronto matters. And I know you don't endorse that, but I've noticed that occasionally, like New Yorkers do here in the States. So we had very interesting times. It was a lot of fun in a way, but I would have stayed in Winnipeg for the rest of my life. Part of that being an abuse dynamic too, which is, you can stay in anywhere if you find a way to do it. But Cheryl she was more motivated, and she wanted to go to UCLA and do a postdoc. I wanted to stay there, but you have to stand by your woman, and so I will follow her wherever she may go. So we both went to LA. I quit my job at clinic. We went to LA, both did postdocs, and mine was in crisis resolution at a place called the Crisis Resolution Center of UCLA. It's a big deal, Harbor UCLA Medical Center, where I got to really get into the stuff even more intensively, do more research, etc. I was there for a while, and then a job came up potentially at USC, being an emergency room psychologist with the possibility of going under the tenure track. I did that for a few years, getting more involved in this stuff, having interesting experiences. When I first was at USC, every case presentation, I would say somewhere in the case presentation, what's this person's abuse history? Have they been hurt lately? And, especially the male staff would just say, I'm sex preoccupied. I'm thinking that things are there when they're not there. These are all false memories and stuff. It's a very interesting thing to start at USC those many years ago, and then stay there all that time. But now I've trained generations almost of psychiatrists and psychology people, and that view isn't there at all anymore. But in those days, it was rather interesting in the first years. But my second father, who was very difficult and dangerous in some ways, was also the very bright psycholinguist, and I did pick up from him the desire to go further in school in terms of a professional job. So I just worked my way up and became tenure tracked, then got tenure, then started getting grants, and then eventually was made full professor, which means basically very little. And that's what happened.
Okay, well, I'll ask a follow-up question, but first, condolences to our friends in Winnipeg that you lost John, even though he wanted to stay there.
I did.
Too many people are leaving Winnipeg, and I have many friends in Toronto from Winnipeg. So now I'd like to, and they always get together. I'd like to roll back this tape.
Winnipeg's a great place. Winnipeg's a great place. I mean, it is true. They say, go for the culture, stay there because your car won't start. I appreciate that, but I love Winnipeg, and I go back every couple of years.
Great. I want to roll this tape back a little bit in terms of your theoretical orientation when you were providing trauma treatment, trauma therapy back then, and how it evolved, where it started, what you added, what you modified, what you believe then you don't believe now, those kinds of things.
So, in the 1980s, and that's how far back we're talking, the trauma field was, hardly even developed. The DSM and other systems ICD had not really come to grips with trauma very clearly. There was the PTSD diagnosis, but it was probably a little overwrought and overused and underused all at the same time, and was too narrowly focused at that time. Because I came from a crisis model, we were not that excited about academic models or theoretical models of trauma, but then again, I had this other part of me that read everything I could find in the academic literature. So I think the early work that I did was pretty much atheoretical or transdiagnostic. At clinic, we were all kind of radicals. We didn't believe in diagnosis. We thought that the patriarchy was the reason why people suffered, which, it's not that wrong, but probably needs a little broadening. Trump has managed to have us broaden it in a lot of different dimensions as an example. I just read yesterday that when Canadians and Mexicans just said one word to summarize the United States, their one word was Trump, which is very, very upsetting, of course. We can talk about Trump if you want. But of course, what happened, the academic part, very interesting things were going on, cognitive behavioral approaches. My first therapy was, as a client, was Gestalt therapy, and I used Gestalt therapy and something called reevaluation therapy, which was prevalent for a while. I don't know if it's still around. Is it still around? Yeah.
Not very much. And it's kind of
Yeah.
been a secret.
It's
Reevaluation
cool.
counseling, Google it.
Yeah, kind of cool. It was actually,
I was
I've
involved
had
in that.
Yeah, I've had people come up to me and say, did you ever do reevaluation therapy? I'll go, oh my God. And it's because they hear some of the themes, the same with Gestalt. So, but one of the things this did do that was maybe helpful, depends on which of my colleagues you talk to about it, was that I developed a healthy questioning about what would later become prolonged exposure, and the idea that you would expose people to very long periods of distress to have them, what was then thought to be, habituate that distress. We now have more advanced models, I think. But clearly I was being more and more affected by a lot of the cognitive behavioral kind of perspectives. But there is actually no, so I think I'm probably a mixture of those early Gestalt reevaluation things. Being in psychoanalysis meant, with a good psychoanalyst who wasn't a classic Freudian, allowed me to take in the dynamic perspective, and then the theoretical perspectives from cognitive behavioral and other perspectives were helpful. And, I've often said that if you want to find out what you think, write a book. So my first book was 1989, and I tried to integrate these various perspectives and discovered that I actually could. I actually felt that I was faking everybody out and trying to sound smarter than I actually was, which was true, but I have more compassion for myself now about that than then. But a lot of what synthesis was to try to find what are these common threads and how does it fit into a broad political perspective about how people are mistreated by virtue of their minority characteristics or their gender or their orientation or whatever. And just sort of developed a model, which is, it's kind of funny when people do review those books, on the rare occasion that they do, some of the cognitive behavioral people would say it's a great cognitive behavioral book that's been translated in ways that relational people can understand. And then the relational people say it's a great relational book with some cognitive behavioral stuff. So I mean, it's almost a Rorschach, I think, but it just reflects the fact, my own belief, that there is no correct model here. We're talking about COVID modeling right now. Everybody's saying there are no correct models. They're just useful ones. Everything's constantly changing. So there isn't any correct model really. And then, because I've done it with your folks a fair amount, about 10 or 15 years ago, I started doing mindfulness stuff and teaching mindfulness. And I've had a long-term meditation practice, which helped me an awful lot personally. Integrating that stuff, which actually integrated well with Gestalt therapy about presence-centered awareness and those kinds of things, has been very helpful. So what you have ultimately is this thing that I do. It's very funny. New Zealand, for a while, you could only work in New Zealand if you subscribe to one of, I think, 4 different therapies, and you could only be licensed if you could say you did one of those therapies. Well, I was doing so much teaching in New Zealand that one of the 4 check boxes was Briere therapy. And I found that hilarious because there was no such thing, and why would you want to do it? But it just goes to show that there was no actual name for it, and there still isn't. I think we don't know diddly. I think that the more we can be, the more we can be open to the fact that in our encounter with a suffering being, we're just as much suffering as they are. We're just in a different position, different level of luck, different level of whatever. And a lot of our job is, can we not be disabled by our own proclivities, but also can we use them to make us wise about the suffering of others? So, I think the newest book, the Treating Risky Behaviors, is my most theoretical book ever. And it is probably some kind of theory, but it doesn't have a name yet. But a lot of it involves, can you learn emotional regulation skills? Can you learn ways to compassionately appreciate your own behavior. Uh, I have a sort of a model of why people cut on themselves or engage in risky behaviors. Can we get at those underlying issues, not by telling them to stop or putting them in jail, but trying to figure out what are the functional benefits of cutting on yourself or punching someone out or compulsive masturbation or whatever it might be. Those are not sick people or bad people. They're people who are doing the best they can with the hand they've been dealt. I don't know what you call that theory, but it's almost like a radical phenomenology theory of saying you have to experience what you have to have the capacity to try to figure out what your client is up against. But luckily, I think, and some of your listeners may disagree with this, I think that cognitive behavioral therapy is undergoing a shift right now, and I'm very much in favor of it. So if you look at Kraski's work at UCLA, a non-habituation model of how exposure works, we're realizing prolonged exposure probably doesn't have to be done. We're even finding out it may not be helpful for some people, and then maybe the 3 minutes of exposure is going to be as helpful. Integrating the EMDR work, not that I'm an EMDR practitioner, I have no problem with it, I don't happen to do that, but probably EMDR works to some extent based on these different models of exposure that don't involve putting people in long-term difficulties. I forget what the question was.
It was a good answer, whatever the question was. you know, uh, what you just said, what we've noticed, I've noticed, is this fusion of the various ideas which used to be so far apart in the 80s and 90s. I remember maybe it was 15 years ago, there was Pat Ogden, sensory motor, was talking to a psychoanalyst, and he was saying, "You're doing such incredible you're doing," and CBT conferences, which maybe 15 years ago wouldn't allow sessions on mindfulness, lately have been an awful lot of mindfulness. So what do you see about these fusions? What's going on?
Well, it is. So one of the major mindfulness packages we have is mindfulness-based cognitive therapy, which was developed by some very brilliant people, but was actually adapted from Kabat-Zinn's earlier mindfulness approaches, which are used even more commonly than mindfulness-based cognitive therapy. So some people, Steve Hayes and others, are referred to a third wave, that a lot of the therapies, but probably especially the cognitive behavioral therapies, can actually do very well with mindfulness perspectives. It fits in. You have to give up some of the things that you were attached to that may not be helpful anymore if you want to take on mindfulness, because there are differences, obviously. There are a lot of differences. But I've always felt like cognitive behavioral therapy shouldn't be called a therapy. It's actually a family of therapies. And I think what happened is that the my way or the highway approach that some of the initiators of CBT developed were not helpful for the field, and they didn't allow CBT to develop the ways that it could. Then you had Marcia Linehan with dialectical behavior therapy. You had these great mindfulness interventions. You had other kinds of approaches that took parts of, because even exposure is the same thing as what psychoanalysts are doing, except it's been reframed and contextualized differently. But it's all about confronting your experience and doing something with it. So there were all these underlying threads in all the different therapies, at least the ones that are helpful, I think, that have allowed us to move in those directions. It's very interesting. If you even look at prolonged exposure, Edna Foa originally said, and a lot of people said, you couldn't allow people to be relaxed or anything other than freaked out when they were undergoing prolonged exposure, because you want them to have the full experience so they could habituate it. It was called the avoidance of safety behaviors. And so if you could find a way not to be too upset in the session, that would actually undercut prolonged exposure from these earlier perspectives. What do we do now? I mean, a lot of people, and certainly in my new book, I talk about that a fair amount. We interleave or intersperse moments of exposure with mindfulness moments, and with breathing things, and with relational interactions, mixing them all up and intentionally doing what was a major bozo no-no in the old days. So, there's still a lot of doctrinaire perspectives out there, but you also have you noticed that a lot of those therapies, it seems so rigid in those days, another generation of people grew into them, whether it's DBT or CBT, and those people brought in other perspectives, and that's the way it's supposed to go. I ultimately think we will have different therapies because they're different kinds of problems, but it's exactly what you said, Michael. They're way more acknowledging each other now than they were before. Even the new psychoanalysis doesn't look much like what Freud was talking about in 1893. It's attachment related. It often has mindfulness components to it. So I think it's all for the good, but I think the real basic bottom line is the reason all these things keep changing is because none of them are correct. They're all just different perspectives, and we have to kind of bring them together. And, I want all of us to bring it together in our own way. Instead of writing a book, you see a client, or maybe you write a book and see a client, but you do the synthesis. And if you don't, one of the biggest dangers is you'll migrate away from the client's internal experience because you'd be so busy operating from a textbook. The biggest thing that we can do is to pay attention to the person in front of us and try to understand what their experience might be.
Yeah, I think we're going to go to some questions. We could carry on this conversation for a long time, but I know we have about 500 close friends kind of watching, and they want to get in too. So here's, I think I see a series of questions about helping trauma clients online now, and maybe some of the differences between sitting face to face and online therapy. Any thoughts about that?
No. I mean, I just don't.
Okay.
I don't do online therapy, and there's a lot of things I don't know, and that would be one of them. I love that you're having these people talk about how you can use regular therapy in the virtual situations. So the world has changed, and we're never going back to the way it was. Even when this pandemic is resolved, there's another pandemic waiting in the wings. I don't think we'll ever do what we were doing. I don't want to get too downer about that. There may be face-to-face therapy, but I think actually what's happening now is the wave of the future. So I love that they're doing all those things, but probably your 500 family members here know more about that stuff than I.
Okay. Okay. Well, someone asked, Jennifer asked, are you able to post, or can people have access to the protocol or programs that you've developed because of COVID in supporting first responders in Los Angeles? Is any of this available? Are the protocol? Yeah, what you're doing now?
I would actually like to share it with you. It's partially my SAMHSA funding, and partially USC has some kind of big ownership of that because it's a program that I just help work with them to develop. I would love to share it with you, and I will directly ask them, and if they will let me, there's a PDF. It's not brilliant, as none of this stuff is, but it's a PDF about just the critical issues that tend to come up when working with first responders and frontlines workers in the COVID era. I'd love to share that with you. We'll see if we can.
Okay. So what we'll do is when you send it to us, we'll forward it to everybody who's watching. Okay. Tough question. I work in the school system with elementary students, and I know we've had a number of teachers and counselors online with us. Can you please highlight some of the behaviors in children who've experienced trauma, which would be observable to educators? Or
would be observable.
Observable. I'm kind of reading this as we're going along, but in terms of young people and children in school who've had trauma, do you any thoughts about how people could help them now in terms of this crisis and what they're going through?
What the kids are going through, or the teachers?
Yeah, what the kids are going through, or the parents are going through, that might be able to help, because I'm sure there are clients of people watching this who are talking about their kids and who are home all the time.
COVID's only been around for a couple of months as we understand it. It's like it was around longer and we didn't do anything about it. But so the synthesis is very early. If I can make a plug, but it's federally, I don't get money off of it, so I guess it's not a plug. But Cheryl and I have developed integrative treatment of complex trauma for children and for adolescents, ITCTC and ITCTA. You can go online, just download ITC, just go Google ITCT and then either A or C. You can download full PDFs of our model for working with traumatized kids. The big proviso is I'm not really actually adept or qualified to talk about the treatment of anyone under the age of 74. No, actually under the age of around 14. That wasn't my training. Those little kids just break my heart. I don't know how Cheryl or any of you folks who work with the little ones do it. It's just amazing to me. So although we've written this stuff, the ITCTC is more Cheryl and then me. ITCTA is more me and then Cheryl. But those manuals are free just because they're federal. So if you just go to my website, johnbriere.com, it'll take you to the project website, which has all kinds of forms and manuals and stuff. We have stuff on working with substance abuse and traumatized youth. We've got one on that Randy Semple and I are just finishing right now on integrating mindfulness into work with traumatized kids, et cetera. I've done a special manual that you can download free there on how to work with self-injurious behaviors, cutting, burning, etc., in kids who have been traumatized. So, I think those resources are available, and I would love for you to check them out. What I can't really speak to is exactly how it would integrate with COVID. COVID is a mixture of trauma therapy, crisis intervention, and compassion for people who are on the bodhisattva journey of helping people in ridiculous circumstance. So it's no longer just trauma, it's something bigger, except that trauma, large writ, is what this is all about: adversity, suffering, etc. So I guess I don't know that I have a real brilliant thing to say about related to COVID, but feel free to download that stuff if you're interested.
And your website, johnbriere.com, is always so full of resources that you share with people. It's great. It's a great resource, so people might want to check your website out. Pre-COVID, great information and support and tests and everything else. A question we've been getting in other of these lunches is the fact that a lot of therapists working online with people are now, of course, similarly affected by what's going on. It's different than the old therapy. And I know a lot of therapists are concerned about, doing this kind of work. Do you have any advice for how, maybe in terms of self-disclosure, appropriate self-disclosure, how they can deal with the fact that they're counseling people in their homes with their angry teenagers and they're having problems with their spouses because they're never apart? So thoughts about that, John, please.
First of all, I think that's how it's always been. It's just the volume is being turned up a little bit more now. I've treated a lot of therapists, and they always tease me about the fact that in the world I'm very self-disclosing. As you know, there's almost nothing I won't say. But in therapy, I'm not very disclosing at all because I feel like it gets in the way. Now, if you can be disclosing in terms of empathy, attunement, response, but unless my clients had heard my workshops, they didn't know about my history, for instance. So it's always been a hard balance between how can you respond to your own life in ways that help you work with others, acknowledge the fact that we're all bozos in the same bus here. And, that's Fire Sign Theater, a nice Canadian reference. We're all bozos in the same bus here. But we just have different jobs and different roles and different levels of luck that allow us to interact with people in different kinds of ways. So, I totally love that these questions are coming up because it's always been about us. And one of the things I don't like about the more packaged programs is they take the us out of therapy. When you look at some of these treatment, one size fits all treatment packages, that's the problem with it. So you might find that the thing that I can send you, if I can, helpful, because we do talk about that a little bit. But, I think it's always going to be how much you're willing to do self-disclosure, but how much is self-disclosure important? Sometimes we want to bond with our clients because we want to help them. Sometimes we want to bond with our clients because we have unmet needs. Sometimes when we start feeling the love of compassion, that turns into generalized love, not necessarily sexual love, but we start getting confused about what it is that we need for our own nurturance versus what would be helpful to others. Many of the people we see are suffering not just from COVID, they're suffering from everything prior to COVID. In fact, some of the most extreme reactions to COVID are in people who've had previous traumas, not that you have to have had that. So, this is always going to be very, very, very complex. I could maybe respond to a specific question about that, but I'd like to endorse it's difficult. You can use it, but I don't actually recommend a huge amount of self-disclosure just because it tremendously complicates the interaction.
Mm-hmm. Okay, let me look on. Well, we have some, hold on one second. People, I think, are looking at different modalities because now they're working online. So someone asks, do you think it would be effective to conduct virtual support groups for family members? Do you have to be more creative? Group therapy online? What are some of the things that you're seeing now online that weren't happening before?
Again, I'm not competent to talk about that except to say I really approve of it, and it is the future. And so what we are finding is that frontline workers are finding virtual support groups online, and that's a really great idea. I think there's pluses and minuses to the cyber world. The pluses are that the accessibility, Sometimes you can do things online. I mean, look at all the people flaming people that they wouldn't have done face to face. You're disinhibited. You're free to do more. On the other hand, some of the I thou gets a little bit weakened by by having a screen instead of a person in front of you. But I do think this is the future. I also think we have to give away therapy even further. We have to make it available to everybody, and that's probably going to happen via the internet.
Mhm. In terms of what you're training and teaching people in the hospital, you gave one example before of someone who was personally affected. What is some of the issues that are coming up right now with frontline workers, healthcare staff? Then we can move to therapists if they're therapists of the hospital as well.
Well, I mean, the big thing is our own personal vulnerability. I think we were used to the therapist as the wise one, and the client as the penitent, who's asking for something, which I've never really endorsed that. Although it does help us with boundaries sometimes, but that's probably not exactly the way to go. What's happening right now is the COVID crisis is laying bare just how much therapists are just human beings, how much we're affected by things. The kinds of things I'm hearing about from healthcare workers are their anger, frustration, and desperation around personal safety in terms of whether they will get infected, whether the institution is protecting them enough. I was just talking to an international physician on the international context a couple of days ago. She was actually being made fun of by wearing a face mask because at that moment in New Zealand, they didn't think that physicians should wear face masks, which is now like required, So, I mean, just huge numbers of things. Oh, by the way, I love New Zealand, and I'm not saying anything about the New Zealand system. That could have happened in anywhere. That clinicians have been getting negative feedback on face masks, especially psychiatric clinicians, for a while now. But that is the future. If you do face-to-face, you're going to have to wear maybe even a plastic mask, but certainly a face mask. So I think it's laying bare those issues. I think that the fear about contaminating your own families is big. A lot of the trainees and young people are not so well. They're starting to get worried, but they weren't worried before because the narrative was COVID won't affect young people. Therefore, basically, go ahead and have your spring break in Florida or something. That was obviously wrong. Now we've discovered two things. First of all, it is affecting younger people, so that was false reassurance. The other one, though, is everybody has a grandfather, a grandmother, or a kid, or a friend, or a lover, or something, and you can bring it home to them. So that level of personal responsibility is also freaking people out because you could actually be doing something to be kind and good and to be helping people and potentially taking a risk of killing your brother or some other thing by coming home and being in whatever state. I think another part of this is we psychological clinicians have some background about recognizing the role of self in this stuff and some training and hopefully some therapy to sort those things out. A lot of ICU nurses, emergency room doctors, plastic surgeons in the burn unit, they have no preparation or recognition of this stuff. And they are used to the one-way model, the top down, I'm the healer, I fix you. And instead now they're running into all the complexities of their own reactions, their own responses. I also think if you don't know that your own responses are big time, then you don't know how to protect your patient or client from them. And so we're getting some people who are having very strong reactions to their own distress that is bleeding over into the medical domain more.
I'm wondering, you're providing great support to frontline people at a hospital that may be very progressive. Do you have suggestions for people in agencies, hospitals, anywhere, of how to support their staff, what the structure might look like? Are they mass phone call, mass video, Zoom sessions, whatever? How can other people follow some of the model that you're using?
Well, again, it's not my model or anything. It's just kind of common sense. And you did, yeah. So the big thing I think the systems are understanding, the infrastructure, is it's in their best interest to take care of their clinicians. And agencies have never taken care of their clinicians, right? I've often said it's not our clients that burn us out, it's the organizations in which we work that burn us out. We need to know the difference. So I think what's happening, of course, is that people are burning out. I don't want to get into it too much, but people are suicidal. People are dropping out of, they're afraid to go back to work. They're having very strong post-traumatic reactions, et cetera. The agencies and hospitals and centers are going to have to take care of people better. It's not that they're malignant forces, but they just aren't put together to take care of clinicians, right? Isn't it sort of true that some of the worst painful experiences you have are in your work? That's supposed to be the most benign environment, and it's some of the worst ones. So it's in their best interest to be doing these things. And what's happening now in some of the ICUs, in my experience, is they're now having breaks this isn't happening in the really heavy duty intense places sometimes, but when they can, giving them breaks to be able to not do 14 hours of ICU straight, having virtual support groups, et cetera. The old solution was just bring them together in the break room, but that's not working anymore. And so how can you do those things? I think that is probably part of the future. The problem is we're all in a state of emergency right now, and organizations are all, I hate to sound cynical, but organizations as they're currently formed are going to sacrifice the clinician for the bottom line of whatever the organization's mandate is. And what that means is that we are sitting ducks because we care and we'll do way more than we have to or should. And that fits in fine for systems that want to use us to that extent. I know that sounds harsh. That's just the human condition. So we are going to have to change those systems or it's just not going to work out. People are dropping out of, you spend like a high level ICU nurse has had so many years of training experience. If he or she drops out because you treated them badly, you just lost tremendous resources. Plus that poor person, how do they define themselves now if they leave with something that they love a lot? I just recently heard a woman tell me that she's leaving the thing that she wants the most to do. That's just heartbreaking. And it's partially because of what she's seeing, but a big part of it is the system that's in which she's embedded.
It reminds me, you're talking about what's going on right in the front lines in hospitals, but even people who are trying to see their clients online. What I'm hearing repeatedly, that working online is much more tiring than working face to face. That's what people are saying. So if you saw clients back to back, either privately or an organization, and you're doing that now, you have to have a level of self-care and know what your limits are so you don't get burned out. Talking to those same clients that you're talking to before, but now you're on a screen.
That's right. You also, I think we're nurtured by our clients. So it goes both ways. And it's important that we don't use our clients to nurture ourselves, but there's nothing wrong with saying this human dynamic feeds me and helps me too. And the internet context you probably get that is attenuated a bit. So you don't feel quite like whenever I'm with you over lunch, Michael, I'm in love with you. Right now, I'm just liking you a lot. Like this is what happens, right? It gets attenuated. And then there you have it. So I could totally, doing so much Zoom work as I'm doing right now, I hate it. It's bad. I mean, I don't hate it, but you know what I'm saying.
Yeah. It's not the same thing. Maybe time for a few more questions. We have a few about people who work with the homeless people, and I know there's a big homelessness problem in LA. So, any advice for them?
Well, so I've worked with the homeless for many, many, many years. And they're almost my reference group in some weird Buddhist sort of way. But we have multiple things here. First of all, the homeless by definition are being marginalized and disenfranchised and maltreated. They're huge hotspots for disease because they're being treated so horribly. They're in outrageous environmental circumstance. It's always been TB. The homeless were depots of TB, but it hasn't even hit home yet how much COVID is raging through the homeless world, and so that's the next hotspot. And right now, overwhelmed paramedics and cops, et cetera, they're not really serving the homeless too much because they've got so much else to do. Plus, every time they go out there, they're at risk themselves, in terms of whether they will get sick. So, I think there's a lot to be said about working with people with radically less resources, et cetera. And the homeless incarnate that in many ways. I guess in this short context, I would just thank you tremendously, those of you working with the homeless, because that is the Bodhisattva journey. That is like the coolest thing, one of the coolest things you could do. Those people need your help more than just about anyone else. It's also very important to know that there's no difference between us and them except housing and luck. And that often we say in Buddhism that that suffering has an impact, but it also broadens us and wisens us. And the homeless, like the burn survivor or the rape victim, these are folks who are actually teaching us as well, and have tremendous amounts of stuff to offer us. This is really true in the homeless world. The homeless, there's no defining characteristic being homeless. Some of them are homeless because they lost a job. Some of them, they're being battered. Some of them have an addiction. Some of them got ill in their health insurance. We live in an archaic world over here in the States where if you if you lose your health insurance, you don't get very good care, or at least you have to wait a long time for it. So they don't speak with one voice, and they're not one monolithic group, but I just commend anyone who wants to add that variable to the mix. With the proviso, they're the same variables that all of us are dealing with. It's just the volume is turned up much higher.
I think we'll have one more question and we'll wrap up. Do you think this crisis will have an impact on finally integrating medical with the field of mental health? I think this can make a change in the future.
I don't like the medicalization of mental health. So I think the medical model has been one of the destructive things that we've had to encounter. And I work in a medical system and teach medical residents and others. And I teach diagnosis, which is medically based. I do think, though, that obviously if medical workers could have more of the technology and understanding and background that the mental health provider has, that would help the medical person provide much better services. I don't know that the mental health person would gain a huge amount by taking on stuff from the medical domain. I say that with some timidity, though, because I work a lot with psychiatrists who do a brilliant job of merging those two worlds. But clearly, it's nobody's fault, but a lot of medical workers are overwhelmed and have limited psychological insights, or they just don't think that's what they're there for, which of course it is in a way. And I do think the COVID crisis is really making us aware of the psychological dimensions of this officially medical problem. But the medical problem arises from social phenomena and psychological phenomena as much as it does due to a virus.
Well, we're going to wrap up. I just want to say a few things before I thank you, John. First, we have a poll next to your question line on your screen. It'll take about 30 seconds just to give us some feedback on your satisfaction, as well as if technically this worked for you. That's important information as we do more of these kinds of programs. In a few minutes, you'll have a copy of this video sent to you, so feel free to view it again if you'd like, to share it with your friends. We have a number of these virtual lunches all available on our website, leadingedgeseminars.org. We're going into what had been a holiday weekend, people planning to go somewhere, celebrate some things, and times have changed. John, thank you very, very much for being with us, really, and continue the good fight in LA, and hopefully we'll get through this.
Yeah, we'll get through it, but it will be different.
Okay, thank you, and have a good day. Bye, John.
Okay.
Bye, everybody
Bye.
else.